Hello friends, in this lesson, this is Sudharshan, and in this lesson we'll talk about the lacrimal apparatus, the most important of which dacrocystitis, and we will see little bit of watery eye and dry eye as well. So dacrocystitis, which is the inflammation and infection of the lacrimal gland as such. So it can be congenital or acquired. So there may be some conditions like nasolacrimal duct blockage or idiopathic fibrosis, or it may be a congenital anomalies, or it could be an infection from staphylococcus, the most common, apart from that streptococcus, pneumococcus and pseudomonas. So the source of infection will be from any nasal infection. So whenever in the pathogenesis, whenever there is a nasal infection, through the inferior turbinate, the infection travels into the lacrimal gland. So why inferior turbinate? Because that is the most accessible structure in the nose. So through the inferior turbinate, it reaches the lacrimal sac where the lacrimation happens, and then in the lacrimal bone, it causes an osteomyelitis and a subperiosteal abscess along with eroding the cortical part of the bone. Then it reaches the puncta and infects the conjunctiva, causing conjunctivitis, and it can lead to conjunctival adhesions or symblepharon. Also it can lead to an exposure keratitis when the lids are affected with inflammation. So the lids become heavy and not being able to close. So this is how the pathogenesis actually happens. And when it comes to clinical features, we have the foreign body sensation, epiphora, regurgitation test is positive, so to see for the mucopurulent discharge coming out, and there will be a mild swelling on the sac as well. The differential diagnosis in this case, we have ophthalmia neonatorum and congenital glaucoma. So the diagnosis can be done using the tear film test, the Schirmer test, and along with that we can also do dacryocystography to detect the patency of the nasolacrimal duct. And when it comes to the treatment, medical line of management with antibiotics, steroids and analgesics, along with cycloplegics and teardrops, and surgical treatment will be DCR, dacriocystorhinostomy procedure. Alright, so let us go into the procedure in very brief. The conventional approach is mostly followed. So when it comes to the procedure of DCR, so first thing, there is a 8 mm vertical incision in the nasolacrimal duct. Then after that, the lacrimal sac will be exposed with the bony lacrimal fossa. Then once we expose the bony lacrimal fossa, the pinkish nasal mucosa can be seen, and after that we make a small vertical incision in the pinkish nasal mucosa, and then we take out the discharge that is coming out from the nasolacrimal duct, and then suture out the anterior and the posterior flaps. So this is briefly the procedure. So that is with dacrocystitis. And next about watery eye. So the etiology, it is of two types, hyperlacrimation and epiphora. Hyperlacrimation is where excessive tear secretion will be there. So it is of three subtypes: primary, reflex and central. So primary, we don't know the cause. Anything that can happen, like any trauma, tumors, infections, idiopathic fibrosis may be seen. Reflex, that is any eye pathology like conjunctivitis, uveitis, corneal ulcer may result in it. And central is mostly brain related, that is emotions. Like when we are sad, we tend to cry, isn't it? So then epiphora, where the tears production is reduced. So in this there can be a pump failure because of the orbicularis oculi weakness, or mechanical obstruction can happen. So as usual, the regular causes, any trauma, tumors, foreign bodies, infections, maybe granulomatous conditions more common, then associated dacrocystitis or idiopathic fibrosis, etc. So when it comes to the tests which we do, ocular examination, regurgitation test to check for the mucopurulent discharge, then fluorescein dye test. The rule of 2 will come here. 2 drops, 2% and 2 minutes will be seen. Then syringing test. So in this we have to remember, for children we will not do lacrimal syringing, only in the adults. Then Jones test is most commonly done. So type 1 and type 2 procedure. Type 1 is like the fluorescein dye test, where we inject the fluorescein dye to check the patency of the nasolacrimal duct and decide upon the degree of staining that indicates the nasolacrimal duct block. Whereas in type 2 we do lacrimal syringing with the cotton bud, and dacryostography, which is a radiological imaging to visualize the patency of nasolacrimal duct with a technetium 99 scan and Anger gamma camera. And finally we have the dry eye. In the dry eye, the causes will be mucin deficiency because of mostly vitamin A deficiency, which involves the conjunctiva or the corneal pathologies. Then aqueous production is reduced because of idiopathic fibrosis or Sjogren's syndrome, lipid related like ibomitis or blepharitis, or any surgical procedures. So the test here will be the tear film breakup time, which is the time between the opening and closing of the lids. So normally around 15 to 30 seconds is normal, and if mucin deficiency is there, less than 10 seconds we can have. And then Schremer test, which is commonly done for Sjogren's syndrome, where we take a Whitman's 41 mm filter paper and fold it 5 mm, which will be a 5 into 35 mm strip, and place it on conjunctiva to see the degree of dryness. So normally it will be greater than 15 mm in 5 minutes, moderate will be 5 to 10 mm, severe will be less than 5 mm. And finally rose Bengal staining, where proparacaine will be used, and based on the degree of staining we can decide the patency of the nasolacrimal duct. And treatment will be the tear substitutes like carboxymethyl cellulose, mucolytics like acetylcysteine, pilocarpine, immunosuppressants like cyclosporine. So that is all with the lacrimal gland. So thank you so much. We will see in the next lesson.